Hannah, am I audible?
Yes, ma'am.
Are you using multiple devices there by the chance?
1 second, ma'am.
Maybe we should start. You need to do the orientation as well, right? Before the faculty join.
Can you hear me now?
You are audible, but I think there is some echo. So,
There is an option. Is it okay now?
yes, you are audible. Okay. I think you can start, Hannah.
Hi, ma'am. Hi, Shipriya.
Hi,
Nice to
hi,
see you.
Paramita. Yeah, long time no see. At least
You're not
virtually.
calling me Shipriya, else I would have been there. I love Kerala. How are you? All good?
All good.
Thanks.
Hannah, we can roll off if everything is okay at your end.
I'm sorry, Shipriya, your voice is, not very feeble. I can't, I can hear you, but I can't make out what exactly you're saying.
Okay. Better now?
Little better, but I'm trying hard to listen. I don't know if it's the same case with Himanshi or is it my internet?
Yes.
You're not very audible, Shipriya. Maybe the earpiece that you're wearing.
You would have to bear with me for today. I don't have a spare earpiece. And anyways, I'm going to be a silent listener only today. Hana,
I,
we can start.
we're just waiting for Dr. Bhalla maybe to join. Okay, he's there. Yes, Dr. Bhalla is here. So let us know whenever you guys are ready. We are good. Hi, Raju sir. How are you doing?
I'm good. How are you?
I'm
Good
good,
to
sir.
meet you.
Same here. Same here. Thank you for taking this up.
Yeah.
Hannah, we can't hear you. You're not audible. Can you hear me now? Yes. Yeah. Okay. So good afternoon all. This is Hannah. So I'm project coordinator at Sparsh Hospice. I'm very excited to welcome you all to the program. So let me explain what we are doing. So Sparsh Hospice is a project of Rotary Club of Banjara Hills Charitable Trust located in Hyderabad. Sparsh is an 82-bed palliative care center that offers free of cost pain management, symptom management, and providing comfort and dignity to those in need. So our free services are also extended to the needy beneficiaries at their doorsteps through 6 fully equipped vehicles, each staffed with a doctor, nurse, and social counselor. So we are also run outpatient clinics to other parts of Telangana so that more people can benefit from our service. So this is all our facilities like infrastructure, wards, private wards, pediatric wards, playrooms, and all. And as I said, our programs are like inpatient service, outpatient service, home care service, and training. So Sparsh has served more than 30,500 plus stories we have created, and more than 50,000 family members are benefited. So we have a well-structured governing board and trustee members. We are 120 members at Sparsh family, and currently we are trying to shape the future of palliative care. For 14 years, Sparsh has delivered compassionate care. Now we are share our expertise to ensure the dignity for all their life end. So on 14th July, Sparsh collaborated with Ashoka University, launched the Sparsh Behavioral Lab, the first of its kind focused on the research, reflection and dialogues in palliative care. And Sparsh will co-host the upcoming IAPCON 2026 in Hyderabad in partnership with Basvataragam. And we also have some training programs like CAS, FCPCV, and GDA training program, nursing training program, and all. And Sparsh is pride and as the part of foundation course in palliative care nursing. So Sparsh Hospice is proud to collaborate with TIPS Pallium India and ECHO India for the foundation course in palliative care nursing. We are conducting the session through the ECHO platform to ensure the effective learning and engagement. So we have 19 session and 50 from 15 July to 28th August is our session. So weekly, Tuesday, Thursday, and Saturday, and the timing is 12 to 1:30. And the ground rules are like minimum 70% attendance, minimum 70 mark in each assignment, submission, pre-test and post-test, and end evaluation. And the learning materials will be uploaded to the LMS platform after each session and will include faculty PPT video link of the complete session, articles, and the learning materials regarding the subject. And the certificate will be issued based on the performance throughout the program. and the all communication would be made in that email ID. Actually, that is my email ID, communication@sparsh.org. And this is the structure of the program. That's it about Sparsh. Thank you. And we have some guests from Palliative India. I'm very glad to welcome you all. So, Dr. Sridevi Warrior and Head Education and Skill Building Department, Palliative India. Sheba RS, Madam, Session Head Clinic Training and Palliative India. Sri Priya Ma'am, Assistant Manager Virtual Education, Palliative India, and Dr. Sushil Kumar, Director, Trivandrum Institute of Palliative Science, and Dr. Hashmant Farhana, led Virtual Education. And we have IECO members also, Dr. Sandeep Bhala, sir, warm welcome. Then he is the Vice President of the project, and Miss Paromita Das, General Manager, and Miss Himanshi. So all are welcome. And from our side, we have Dr. Raju. He's the senior consultant here, and he's taking the training part and all. And we have Mrs. Anusha Chikati, and she's the head nurse here. She's the echo facilitator also. She have been here past 10 years. So she's a long-term member for us. So welcome you all. Sir, Sandeep sir.
So, a very good morning to all of you. And first of all, I would like to pay my sincere gratitude and thanks to Sparsh organization, Sparsh Hospice, as well as the TIPS Pallium India. I think this joint initiative of Sparsh TIPS Pallium India for creation of the cadre for the palliative care in the nursing scenario is going to be a game changer for the country. And let me tell you that this is a collaborative effort which happened in the month of May with the help of TIPS team. I would like to pay my sincerest gratitude to Dr. Sridevi Warrior at Education and Skill Building Tips. Also, Dr. Veeraswara Raju, Head of the Academics, and all the senior colleagues, those who have joined from today's initiative to encourage, facilitate, and spread awareness about palliative care through education, training, and extending services. ECO is working with the TIPS India since so many years, and they are acting as one of our super hub also. And I would like to pay my gratitude to Dr. Raj Gopal sir, because under his kind leadership, the palliative care services has been expanded all across country. And being a father of palliative care, I think he has taken up this mission in a very, very extensive mode. And that is the way that we all have come in touch with him, and we started just expanding the portfolio of his passion by joining hands with the eminent organizations like all of you. ECO, which is Extension for Community Healthcare Outcome. This is a not-for-profit organization working in the field of capacity building since 2008 by creation of Eco India Trust. And Eco India Trust operation started in 2015, and we believe in a hub and spoke model. And we have the people from the different parts of spheres, from different parts of country, they can join and they can have the interaction with the eminent hub team specialists. And it's a three-way interaction: hub team with the respective participants with the among themselves, and participants with the hub team. And then at the end, you will get an evidence-based solution with the queries and the issues which you are facing into day-to-day practice. The journey, those operations started in 2015, and today we are sitting in 2025. I'm very proudly, I can share with you that we have partnership with almost all the national health missions, Government of India. We are working extensively with the majority of the nursing councils. 14 nursing councils are there on board with us. 20 AIMS are there on board with us. 3 Directorate of Medical Educations are there on board with us. And some of the Ayush departments also we have started expanding. Health is one of our major portfolio, but recently we also expanded our wings from 2015 onwards into education, as well as from 2023 onwards into agriculture and livelihood also, and climate change also. So I think Eco, which is a telementoring platform, it can give you an opportunity to learn. It's a learning platform. It's not a teaching platform. This is a platform which can give you the opportunity to interact among each other. And the way this program has been constituted, that thrice a month the sessions are going to happen, and total 19 sessions are, you people are saying it is there. I think it is a one of if you see the number of the session wise in eco, I'm since I have joined, I think this is one of the biggest initiative number of session wise which I am seeing now, which is happening. I think it is a great learning for us also to learn from the series which you are going to start today. So on behalf of my senior colleague Ms. Paramita Das, who is leading this, and all other colleagues like Purnima, Rajendra, we are really grateful and thankful to you and all other team members of Eco India, as well as from the leadership of Eco India. We wish you a very, very fruitful and interactive journey. All the best. Stay safe and stay healthy and enjoy this fruitful learning experience on Eco Interactive platform. Thank you.
Let me introduce Mrs. Anusha Chikati to introduce the faculty.
Ma'am, you're muted. If you could just unmute yourself, please. Yeah.
Good morning, everyone. This is Anusha. I'm working as a head nurse at Sparsh Hospice. So today I want to introduce Miss Alice ma'am. So she's very known person to me personally also. She's my mentor actually. I'm proud to say that. So welcome ma'am. Welcome Miss Stella ma'am. So she is in nursing training and service in Indian Army. She joined medical college in 2006. Since 2007 she's in palliative care. She's a national faculty and presented papers in international conferences of Indian Association of Palliative Care and has conducted more workshops. And also she got International Excellence Award in Palliative Care. And she has contributed to many chapters and scientific writing in a palliative care. Welcome, ma'am. Today she's a speaker and she's talking about introduction to palliative care nursing. Introduction to palliative care, sir.
Thank you, Anusha.
Hello, ma'am.
And thank you, Sparsh, for giving me the opportunity. In fact, Pallium India also to give me the opportunity to talk to you. First of all, let me say one thing. It's heavy rain over here, raining very badly. Okay, so I don't know about my internet. Hope you people can hear me. Am I audible?
Yes, ma'am. Yes.
Okay. So thank you all. I'll just share my screen.
Yes.
Okay. So I'm going to talk about this one, palliative care. So the topic is introduction to palliative care. Okay. So what is palliative care? That's what I should ask everyone. What is palliative care? You can put your the response in the chat. I think almost 36 people are there. So if I get one or two response, it will be good. What is palliative care? Okay. End of life care, Roshni. Okay. Any other, this one? Other than Roshni, no one? Supportive care start from time of diagnosis. Dr. Sunita Rani. Care given at end time to for easy death. Suhail. Okay. So let us see. What is it? See, the WHO definition of health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, right? You can see in 1948, and where we see the 7 dimensions of the wellness also you see. That is physical, it is their academic career, social, cultural, environmental, financial, spiritual, and emotional. So this is the WHO definition. Curiosity is the engine of achievement. Who, what, when. So same thing, if I ask the palliative care also, if I go through all these things, you start thinking what is palliative care, when to give palliative care, how to give, who has to give, where to give. So this goes on when, what, and all. Okay. So someday we all will die, right? That is what Snoopy is telling to Snoopy. True, but on other days, we will not. When we take our patients also, they will die one day. But before that days, what they are doing? That is very important. Even for us also, we all are leaving. Someday we know we will die. But the other days, we are not dying. We are leaving. So when we are leaving, that days we have to make better. That is what everyone needs. And life isn't about waiting for the storm to pass. It is about learning to dance in the rain also. Okay. It's easy to tell, but when we look into, when something comes ahead, we need to go through that. And we will be able to go through that only when we get a good support from everyone. And that is also an important thing. We need our family support. We need the healthcare professional support. We need social support, financial support, spiritual, all the support we need. So if we get a good support, we too will dance in the rain. So it is just like asking for the blind people what is palliative care, or just to know what is palliative care. You see, the elephant, they said it is a snake, it is a spear, it is a fan, it is a wall. Different things they have in their mind. Same thing. If we ask some people what is palliative care, like someone said, Roshni said it is end of life care. The other person also said end of life care. But is it end of life care? That is the question. So, perception is reality, but not always the truth also. So, symptom relief, psychological support, social, spiritual, financial support is very important. With what? With a good quality of life. Till the patient is alive, right from the diagnosis to the end, the patient needs a good quality of life and a good end of life care. And of course, a peaceful death. Globally, if we see the global gaps in palliative care, you see here, 86% of the people who need palliative care do not receive it. So how many people are receiving it? 4%? 83% of the world's population lack access to pain relief. Still, people are there who are suffering with pain. Recently, I had been to one place where I found the patient was really in pain. And what was given for the pain? That is another thing. Okay, so still, places are there where the people are suffering due to pain. There is no proper pain relief. And 98% of the children needing palliative care live in low and middle income countries. So only about 14% of them receive it. So the evolution of the concept was palliative care is the active total care of patient and their family at a time when the disease is no more responsive to curative treatment. So if you take, if you go back, many times it happens when the curative treatment is not, and it was more focused on cancer also, I should say. If the curative treatment is not responding, they used to send the patient to palliative care for a total care. But In 2002, the WHO definition of palliative care changed, where they said it improves the quality of life of patients and their families. So palliative care approaches and improves the quality of life of the patient and the family when they face a life-threatening illnesses. Through what? Prevention and relief of suffering by means of early identification, a good assessment, treatment of pain and other symptoms also. So it is physical, psychological, social, and spiritual. So that is the concept. That is the 4 domains of palliative care. It's not only physical, psychological, social, and spiritual. We need to see all these 4 dimensions. So quality of life is what a person says it is, because it's a subjective, giving satisfaction in the life. And it is influenced by all the physical, psychological, social, and spiritual. A person who was in end of life care, she told, if I have a small piece of tapioca and then I die, I'll be happy, and that is my quality of life. That's the satisfaction she wants. So I always do tell her, quality of life is not only pain relief or other symptom relief and all. Quality of life is what the person say it is. If the person is saying that I want a piece of chocolate, even if I am highly diabetic and I know I'm going to die, but it can improve my quality of life, I feel, I always say to myself, quality of life is that. Because that gives satisfaction to that person. And so, where is palliative care provided? Don't think that palliative care can be provided only in a palliative care setup. No. You can give it in your wards where you're working, in acute care hospitals, in ICUs, in any unit, in a hospice, nursing home, community health centers, and also in the home setting. See, wherever you are working, you can give palliative care. So now what is palliative care? You already know now. That's the 4 dimensions: physical, psychological, social, and spiritual. And any patient admitting to a hospital under any specialty, whether it is acute or chronic, they undergo all these 4 concept problems. But maybe little up and down, that's all. But they too we need to address these problems. So palliative care is, palliate means elevate suffering. That is to lessen the pain. Pallium, when we say, it is like a clock or a cover. Cover in the sense, we are going to cover all their symptoms, all that 4 domains. With treatment primarily aimed at patients' comfort. We need to see the patient's comfort, not our comfort. See the patient's comfort. If the patient is saying pain is not a big problem for me, I would like to play with my grandchild. For that patient, that's a quality of life. And the patient is comfortable with that. He may forget about the pain. So don't say to the patients, there is nothing more we can do or I can do. Okay, in most of the time, I just want to ask you a question. A patient who had a stroke with a NGT in situ and with an indwelling catheter is discharged from the hospital saying that nothing more to do, you people can take care at home. Now, my question is there nothing more for the patient to do? Is there anything more that we have to do for this patient? Any response? Just think and let me know. Stroke, NGT is in situ, indwelling catheter is there, and we are just saying there is nothing more to do, you can take home. Nothing more to do for this patient? I just want to see if somebody has psychological support, music therapy, okay. Anything else? So you people also are standing by the same this one. There is nothing more to do. You can take home. Hmm? Why nobody is answering? I think they are supporting that that statement. There is nothing more to be done. Only who is this? Shivakumar. We can do what they wish. Anything else, Shivakumar? You said psychological support. Because others are not responding. Just as a nurses, it's not only counseling. Like, more than counseling, there is a very important thing. I told you the patient is in NGT tube. The patient is in indwelling catheter. And we are saying nothing to be done. The patient needs a full nursing care. The patient may be having pain. He needs a pain management. He needs a, what is that, physiotherapy. We have to teach them how to give the feed, how to take care of a catheter, how to give a bath, how to make a bed, how to give a oral care. See, head to foot, all the care they have to do at home. Because the patient is still alive, patient has not died. Our statement, there is nothing more we can do, is a very wrong statement, in fact. And that is why palliative care is saying there is always something we can do for the patient. Very right. There's a lot and lot of things that we can do for the patient, even if they are discharged from the hospital. It's not only about a stroke patient. You can take in any such patients. Cardiac, liver, this one, liver problem, any other problems, respiratory problem, any other problem. This all patients need care at home in a different ways. So the present concept is not just for life-threatening situations. Linda has told about it. Elevation of suffering is needed for all who have curable disease also. Just like incurable disease. Of course, chronic patients need more, but everyone, that's what I told, each and everyone who is admitted in a hospital needs palliative care. And what is new about palliative care? If we say, there is an old world medicine reborn, the revival of the whole person approach. Okay. I was just telling the other day when I was taking a session, I was saying, previously the doctors were very good in their clinical judgment because there were no what scan and other things. Okay. I have come across many doctors just looking at the patient and their problems and their palpation and that percussion, they will say, yes, this patient is having so and so thing. The diagnosis. And of course, that whole person approach has come. That is physical, psychological, social, and spiritual. Now, the palliative care is included in our BSc fourth semester syllabus. It's only 20 hours. Hopefully, let us think that there will be a separate one subject as palliative care in BSc nursing or MSc nursing, even in GNM. I don't know why it is not being done in GNM, because GNM also, they are also nurses. They are also working at the bedside. They too need to know about palliative care. Just like medical, surgical, gynecology, palliative care also should be there. We are open for that. And many specialties have started integrating palliative care, especially the pulmonary. people, neuro people. And advances are made in pharmacology. That is how to use the medicine. Some medicines we think that this is only for psychiatric. We think this is only used for this one pain or something like that. Okay. But now palliative doctors know what medicine we have to use. It's not only for one thing. It has got other uses also. Surgery, palliative procedures are started. Radiative, palliative, and palliative radiotherapy, palliative chemotherapy. So much advance has been made is come in palliative care. So let us see now. This is the old concept, what you are saying. Curative treatment, then once there is nothing, they will send to palliative care. Almost when the patient is end of life care, someone told like end of life care. No, palliative care is not end of life care. One of the components in end of life care is also one of the components. That's all. Palliative care starts right from the diagnosis. If you see, it has to be started right from the diagnosis. You see, this is the modifying treatment. There is curative treatment. This is supportive and palliative care. So once at the point of diagnosis, the patient is in palliative care. As the days goes, you see, this usually reduces. You see, narrowed. But you see the palliative care, it was narrow here, but it is broadened. And here is the place where the patient is on end of life care. Patient is facing the death. And of course, after the death, that bereavement care. That is very important. Do not leave your patient after their death. The family especially. We need to find out also what is happening with them. And that is why in palliative care, home care is very important. We say the backbone of palliative care is in the home care. Because you have seen the patients in the palliative care, you are sending them back. Please keep a follow-up of that patients. Otherwise, there is no use. So the palliative care says provides relief from pain and other distressing symptoms. Dyspnea, nausea, vomiting, a lot of things are there. Affirms life and regards dying as a normal process. Once we are born, there is a time we have to leave this world. We cannot stay back here for thousands of years. So it's a normal process, death. And neither we are going to hasten or postpone death also. And in palliative care, it's not only the physical problems, but patient's psychological, social, and spiritual aspects are included in patient's care. We need to address all their problems. And we support, there is a support system to help the patient live actively as possible until death. That's what I told you. Till we die, we need to live actively. And of course, it helps the family to cope up during patient's illness and in their own bereavement. Because grief starts before the death. Both the patient and the family, they start grieving when they hear about the diagnosis. And the grief continues after the death of the patient. So we need to approach them, find out how they are coping up for the loss. We enhance the quality of life, see, during the course of illness. And of course, it's not that only palliative care. We can give the other therapies also to the patient. Chemotherapy, radiotherapy, music therapy, art therapy. So many things have come nowadays. Okay. It's not that palliative care means everything has finished and the patient is there. No. Here in our setup, even the low backache patient having severe pain, radiating pain, okay, they come to palliative care for pain relief. It is not that they are in the end of life. So globally, I told you only about 14% of people who need palliative care receive it. And every year, the World Health Organization estimates more than 56.8 million people need palliative care each year. That is what is happening. And if you take India also, palliative care among the females, it is about 9.64 per thousand. And you see the male, it is about 6.77 per thousand. And it is found that highest among the participants are more than age 60 years. And if you come, our aging population is going to triple the number in 1950, they are saying. Okay, you see in 2009, it was 70 crores. And in 2050, it is going to be 200 crore elderly person who will need a palliative care. So now, no matter whatever we eat, healthy food, whatever it is, have a good sleep, doing exercise, anything, one thing remains, that is one day we have to die. Okay, but what kind of death do we prefer? Sudden death or a period in the bed, unpredictable, steady deterioration, or many times when we talk to the patient, their doubts are how I will die, where I will die, whether I will suffer when I die. And these are things, the fear which the patient do have. So over 30 million people with incurable disease suffer unnecessarily because of severe pain and other symptoms. Pain is one of the main things. Even a small headache, we won't be able to concentrate in our job. So you can think of our patients who are suffering pain. So who needs palliative care? Of course, geriatric population, cancer patient, pediatric palliative care. But you see the other thing also. Neurological, cardiovascular, chronic kidney disease, chronic liver disease, chronic respiratory disease. It just goes on. Everyone needs palliative care. So there are many models of palliative care. If you ask here, we have inpatient department, we have outpatient department, we have home care here. Okay, in some places only consultation is given and the patient is sent. Community-based palliative care is there where we have only the OP or the home care visits. Some are only supportive care for the patients. Hospice care where the patients, during the end of the life, the patients are in the hospice. And of course, rehabilitation is also happening, especially in some cases where the psychiatric patients, they are being rehabilitated. So rehabilitation also can happen. So everywhere we can do palliative care. It is a small scenario, 52 years, hypertension, diabetic, 5 years, since past 5 years, not on any medication, had a stroke about 1 week, left-sided weakening, having problem with bowel and bladder incontinence, finding difficulty in swallowing and speech, renal function showing creatinine raised. His wife is the caregiver, 4 children left with their old grandparents. So think, what are the care to be provided in the initial stage and followed by the discharge of the patient? Okay, so initial stage you can see. Just tell me what are the things we have to give for this patient in the initial stage? Just can you respond? What are the care to be provided in the initial stage and then follow during the discharge? I hope all are attending the session, or all the symptomatic management. All the symptoms we have to say, right? Because patient is having bowel and urine incontinence, swallowing difficulty, speech, even this one creatinine is raised. Okay. So in the follow-up, what will happen? Bowel care, bladder care, speech therapy. Maybe if the patient is put on any, NGT tube, that care we have to give. So yeah, patients need the nursing care, physiotherapy, exercise, right? So this is all we have to do. And doctor says condition can be improved with proper management. What are the support needed for this patient? Someone told about the physiotherapy. Maybe with a good physio, the patient can become independent. He can do his own things. We can teach after some time, maybe we can teach the patient about the bladder exercise. We can remove the catheter. See, a lot of things we can do for this patient at home also. Full nursing care we have to give for this patient, head to foot. And the very important thing, we need to teach the caregiver also, because she's the person who is going to take care of her husband. So she needs to know what all things can be done, how to make a occupied bed, how to give a rice tube feeding, how to care for a bladder and a bowel. Okay, bladder care. How to care bowel. For proper, and the patient can improve. As I told you, palliative care, of course, culture. Culture is also very important. Everyone, even though we have the religion, of course, many religion, Hindu, Muslim, Christian, Sikh, like this there. But in that itself, the culture is different. Maybe we don't know about their culture, but try to find out at least. And the care of the patients who are dying actively. Now, supporting team to improve the quality of life. Who all need? We need the nursing people, social workers, maybe a chaplain, occupational therapist, any role for the creative art in palliative care, dietitian. Many people do ask, why dietitian? We need to give them what diet they need to eat. Of course, nurses can learn about it and they can do it. Physiotherapist, speech and language therapist, clinical psychologist, pharmacist, and medical rehabilitation and palliative care patient. Okay. So main three things I'm talking. See, I'm talking about the introduction to the palliative care. So in the introduction of palliative care, these three things are very important. Our heart, our head, and our hands. That is attitude, knowledge, and skill. You cannot just, without attitude, knowledge and skill is not enough. Just attitude and skill, no knowledge, again gone. Skill, we need. So all three goes hand in hand. As a health professional, you need all these three things when you are working with a patient and family. Otherwise, you are not going to give your best to the patient and the family. If you don't have an attitude, you won't take care of a patient properly. You need the knowledge how to take care of a patient. I don't say that everything you need to know that you have to be very perfect. No, I don't say that. With you, if I compare with you people, there's a big gap. Because you people are in the era where new technology has come. I was in the old era. Okay. So new things comes. I need to learn about that if I'm working. So that is the knowledge. And when I get the knowledge about something, I will improve my skills also. That is the hand. So the 3H is very important for the health professionals. Okay. So there are advanced skills in palliative nursing also, nursing care. That is, we need to know the emotional resilience, assessments of this, how to assess the symptoms. What is advanced care planning? We will maybe having some sessions on that. How to collaborate with other specialties, have compassion for the patient. Counseling, of course, nurses need to know a little bit of counseling also. And of course, spiritual care. And critical thinking is very important. Nurses working in advanced level, I don't say in advanced level also, nursing working in palliative care or in any other setup needs, should have a very good reasoning, critical thinking, and how to reflect it. So the skills in assessment comes how to assess a symptom and manage it, because it improves the quality of life of the patient and the family. Advanced care planning. The patient need to know what is happening with the patient so that they can plan what type of management they need, what type of care they need. That is decision making. So you need to be good in your communication. Pain management. Primarily, we focus on the palliative care, focus on pain management so the patient is comfortable. Patient and family assessment, an important aspect of palliative care. We need to find out from the family also what are their goals of care, both the patient and the family. And of course, informing the family about the care and the prognosis of the patient. What is happening with the patient day to day? Even they need to know what are the symptoms that will arise during the end of life care so that they can take care of the patient properly. I remember one patient, a patient's family, they just made a call and told me that we were able to take care of, especially that wife, she said, I was able to take care of my husband very well just because you people told me how to take care of the patient when the patient is in end of life care. And I could make also that what was the changes that has happened in the end of life. They never rushed to the hospital. So there are 4 pillars of practice in nursing practice. Again, it is in palliative care. Clinical direct care you can give. You can be the leader. You have to have collaborative practice. Improving the quality and developing practice is very important, and developing self and others. So when you see this trajectory of the chronic illness, you can say when you have a short-term evident decline, okay, you are running, then suddenly there is a decline. In one thing, you see that's a long-term limitations with intermittent serious episodes. Every now and then you go to the hospital. Intermittently, you're having problem. We can take like this COPD patients and all. Okay. And the last one is frail patients or this one, Alzheimer's patients, this one. Okay. And there is, of course, one more thing is the sudden death. You're going well, suddenly you had a heart attack and you're dead. The question is, imagine holding this glass of water. How long you can hold it? In all these cases, in all these trajectories, how long you can hold a glass of water like this? There is a limit for it, right? At one point, you had to give it off. Same thing, when I started, I told you, at birth, we are born, then we are to die. We cannot hold our hand for a long time like this. At one point, we have to put it down. And that is what we have to see also. So when we see a meaningful palliative care, it requires a combination of socio-economic, cultural, and medical solution, because culture and socio-economic factors are very important, especially when the patients are facing death. So as I told you, these are the domains. And when we come for the domain care, physically there are a lot of problems, psychological, spiritual, and socio-cultural. These all four dimensions, all four domains are important. And it is prioritized according to the patient's priority, not according to your priority. If the patient says, I'm anxious, it means the patient's psychological problem are more than the physical problems. Patient is having pain or nausea, vomiting, but the patient says, I'm very anxious. So all these four domains are important. So when we study the structure and process of care, which begins with a comprehensive assessment and a care plan, and that goes with the consistent with the patient's values and goals. Advanced care planning and, of course, non-medical needs has to be expressed more frequently also the patient. See, illness is a person's subjective experience. Disease is the underlying pathology. Okay, and sickness is the social and cultural conception of this condition. And I'm not going. So what do the patient with serious illness want? Pain and symptom controls. Avoid painful and prolonged death. Just tell me how many of you, when you see a patient in ventilator for a long time, there is no improvement, feel bad for the patient? See, painful. They feel they should have a sense of control, relieve burdens on the family, and of course, strengthen relationship with the loved ones. If you talk properly to a seriously ill patient, they will tell you what they want. It's not only physicals. At times, they talk to you about their psychological problems. They talk to you about their family problems. And sometimes even they will tell you that I'm not in good terms with my brother, sister, mother, father, whatever it is. I want to meet them before I close my eyes. Reconciling. So many things are there. But most of the time, we don't address this to the patient and the family. So, beyond the concept of palliative care, concept which is physical, psychological, social, and spiritual, what about the financial? So here we have to think. A cost-effective palliative care has to be developed for the patient, especially when the patient needs physiotherapy, occupational therapy, psychotherapy. I usually tell the nurses, why don't you people learn what the physiotherapist or the occupational therapist is doing? And you can help. Even to the patients, I say, you can keep a physiotherapist or occupational, but after some time, better you people can do it. Learn from them. And of course, home-based care is very important because that it is set up in the villages. Integration of palliative care, this already I told you. So, integrated palliative care involves bringing together the administration, organization, clinical and service aspects. And this network will work out very well. Because if you're seeing a patient in your setup and you want to send up the patient in somewhere in a village, you need something over there so that the patient will be taken care. So believing will, I'm not talking, I just tell you that you all know that nowadays people all started writing and keeping that where they want to die. What can be done? Some living will. Okay, I hope you will have a session on this. And so integration is very important because patient and families, their demographics, culture, personal values, belief, practices are very important in all these dimensions. So integration of palliative care in every specialty is very important. This one I told you. So, palliative care is not new also. When we take the history, it has an old tradition now. Okay. It means hospice, hospital. Host means guest. So in 1960s only, the revolutionary changes happened in UK. But when we go for the institute, there were about, I think, 60 or 70 institutions were there. It's like a hospice concept during the era of Emperor Ashoka. So in 19th century, there was no practical difference in a hospital or a hospice. You see, 18 institutions were built up by King Ashoka during his reign. So there was a hospice like a concept during, it's an old this one. And the first time the term hospice was used in France for a terminally ill patient, 1842. Okay. So the 1982, the Cancer Division of World Health Organization under the leadership of Dr. Jan, they enlisted the help of leaders, cancer pain specialists, and pharmaceutical manufacturers, develop a global program for cancer pain relief. Actually, palliative care has come as a cancer pain relief, and slowly now it has entered to all the specialties. So the history is hospice of medieval Europe. That is in 1879. The ladies' hospice in Dublin, that is the Mother Mary Icons, Irish Sisters of Charity. They developed their first hospice in the context of the patient care. The first hospice in India, that is in Pondicherry in 1876, you can see. And some old people's home, which was run by the Sisters of Notre Dame du. This is a person who gave the term palliative care in 1975. Dr. Mount has traveled worldwide promoting and explaining palliative care and coined the term palliative care. So, Cicely Saunders, she's the person who first opened the first modern hospice in London, and it is called as St. Christopher's Hospice in 1967. Okay, she's a social worker, she's a nurse, and she's a doctor. She's just not a doctor, she's all three. And she opened the first modern hospice that is in London. Okay. And what she said is about how people die remains in the memory of those who live on. Yes. I have heard patients, families saying that last moment we cannot forget in the hospital, how my father died, how my mother died, otherwise how my grandfather died. Very painful, restless, rolling on the bed. He was swollen, many things. But think, the person who has died and gone from this world, he has gone. But think about the family, whole their life till their end, they'll be remembering this. Just 1 second. Anuda, I'm in a session. Okay, I'll call you back. Huh? Okay. So good quality palliative care can be defined as the care which I would be happy to have given to a member of my family if he or she was dying, or to receive myself when my time comes. For me, my parents' death was a good quality, and I remember it is as very sweet thing. Good memories. My dad and my mom both died at home only. But that's a good memories for me because I was able to do many things for them. As I told you, giving a small piece of chocolate, something what they want to eat. Many things was done for them. So it is a good memory for me. So the philosophy is, they say you matter because you are you. You matter to the last moment of your life. And we will do all that we can, not only to help you die peacefully, but to live until you die. Just think, how many patients come in front of you daily? How many of them go home? How many of them leave this world? Anytime have you addressed their psychological, social, and spiritual or financial problem? Did you spend some time with them? Just sit at their bedside, talk to them, or just routinely doing all that routine work, taking vitals, giving medicine, and just walking off. Patients would like to see a smile on your face. They want you to ask them how they slept last night. Was there any problem? It's not that the person who is handing over saying that bed number so and so has did not sleep last night, he had a pain. And like Gilliburn says, I also always tell, please don't tell bed number and the patient as a case. Don't see a patient as a case. They have a name. It hurts, at least in front of the patient. CA breast, bed number 6. See, when we are handing over with the case sheet, just explain to them, hand over properly. And when you take over, okay, if I knew that patient was in pain, I can just ask the patient, how is your pain? The patient will know that, oh, you have been handed over about my pain last night. And if you have not, at least go and ask the patient, how was their day and night? What was their problem? And please don't forget the family member. Just turn to the family member, ask whether they had their breakfast, whether they had their lunch, or whether they brushed their teeth. They are also equally important because they are the person who are taking care of the patient. To a small group of nursing students, when I told them, go back to your wards, talk to your patient also, please just ask the bystander also something. And one of the nursing students, when they had come back, she said, they entered the patient's room, they asked the patient whether the patient had a lunch because it was lunchtime. And they just turned to the patient's mother was there. They asked her, Auntie, you had your lunch? And the girl, and then I asked, what did the family said? I mean, the mother said, she said, she just came and hugged and said, this is the first time I'm hearing someone coming and asking me that whether I had my lunch. They are also equally important. See how much the patient is suffering, physical healing. Same thing, same suffering the patient's family is also having. Maybe the patient is having severe pain. They don't have that body, but at least they are also feeling that pain. That's what we call empathy. So palliative care, don't keep away the patient's family. We have our patient with us, with the family. And it's not end of life care. No. We have end of life care because we give symptom control, pain relief. There is end of life care also so that we can see that patient is having a good death. So next time somebody asks you what is palliative care, please don't say it is a end of life care. Palliative care tries to improve the quality of life of the patient and the family when they face a life-threatening illnesses. Simple. So from 1960s to 2020, you can see. By 2020, when the COVID was there, we had telemedicine also. So in many places, nowadays there is a telemedicine is happening. We can call to the patient. Of course, if you have this one mobile also, nowadays video calls also is happening so that we can see what is the patient doing once the patient goes back to the village. We can make a good follow-up for the patient. But still there is a lot to go. This is Shanti Avedana. The hospice in Mumbai. 1985 it started. Okay. So before ending up, I would just I'd like to tell you that wherever you're working, use all your three H. Don't keep one aside and take only the other two. No. And just see that your patients are comfortable. Their problems are addressed. Give time to your patient and the family. For us, when we feel that the patient is counting the days, the patient and the family. But if you see, make the days count. And how long they are going to live in this world, that days make it better. If you give a very good care for your patient, somewhere in one corner of the place, if they see you, they'll come running to you and tell you. Maybe you won't recognize them. They will say, "Sister, you were the person who has taken care of my father." It's not because that you have given some money. No, we didn't give anything, but we gave our full to the patient and the family. That is, we have taken care of the patient and the family. And that is the important thing. So palliative care, all the 4 domains is very important. All you nurses, you all know that when we learn, when we have stepped into the nursing career, we are taught all these things. But we don't address these things. That is very bad. Because we always depend on the patient's family. Because they are there to take care of the patient. So we just routinely do our things, giving injections, medicines and this, just like that. No, if 100 patients are there, at least 5 patients may need your time. Take time and talk to the patients. Find out what is their exact problems. If you assess properly, doctors will give them a proper management, proper treatment. So your assessment should be proper. That is very important. Even a minute thing you need to assess. So assessment is very important because good assessment, appropriate man treatment can be given. So I have only this message to you. Okay, thank you all.
Thank you, ma'am. Dear participants, if you have any questions, please put it in chat box.
I told you 14%.
One. I think everyone says thank you. So everyone understood, I think so.
Aisha, they all are from working with you or they are from different places? Where is attending this?
They're in different places, ma'am, actually. They're the nursing students. So me and Hannah from Sparsh Hospice.
Okay. They are only from Telangana or
Different states, ma'am, actually.
different states? Okay.
Yeah,
Okay.
they're
Good.
the nursing students in nursing.
Mhm.
All over the India.
That's it. So, oh, somebody is attending from Tamang. Oh, good.
Yeah.
From Sikkim. Mhm.
Dear participant, if you have any doubts, please ask to ma'am. Ma'am is here actually to clarify our doubts.
Scheme, Jammu Kashmir. Good. From different areas.
Yes, ma'am.
Rajkiran, Andhra. Uttarakhand. Okay, good. So once again, thank you all so much. And thank you, Anusha, and your team. And of
Thank you
course,
so
Palliative
much.
India.
Thank you so much.
Okay, so I'm just leaving.
Sure. Thank you.
Am I? Am I audible? Am I audible now?
Yes, ma'am.
Participants who all are not registered at that IEGO platform, please register. So if you are facing any problem, you can text me or you can mail me. So my email ID I'll share to that group. If you are facing any problem, you can directly message me.
Anyone having any doubts regarding this session?
State in చెప్పేసి మాట్లాడండి ఎనీ డౌట్స్ ఉంటే నో డౌట్స్
Thank you, everyone. Thank you so much. Please share the feedback.
So we will share that feedback link on group. So please share the feedback. You guys can leave now.
No, you can end the meeting. You have the access. And one person has said that please share the PPT.
Akshay,
I
are you
think
saying
that will.
something? I can't hear.
Sorry,
I
can
think.
you hear me?
1 second. Yeah, okay.
So one person is saying to share the PPT. So I think that will be uploaded in the platform, right?
Yes, ma'am. Yes, you mentioned.
So everyone will be uploading the presentations in the platform with the video as well. So you, if you are not registered in the platform, please register yourself. If you face any issues, you can put it in the group, or you can directly reach out to Hannah. And we'll be sharing the feedback link in the chat box in the group as well. So please fill that feedback form as well. Thank you.
And please register that IECO platform.
Yes. You can end the meeting. Can you see end meeting option at like right
Yeah.
bottom right? Please end the meeting.
So what? Okay. I'll call you.